Hi, good evening everybody and welcome to these discussions about the INI-CET questions asked today. And a lot of questions which have come have already been discussed so many times in our discussions in so many multiple forums where we meet. But the bottom line is always that we never get to know what they want to know as answers. So yes, there is always a problem with the choices which have been given in the exams and what my friends have recalled and given us and what you people have told us. There's always that problem, but there's also another problem that what do these people want to get as the right answer. So yes, we give you the answers with the experience which we have and the amount of work which we're doing as clinicians and the number of patients and the cases we've seen and what we've been following in medical colleges as the teaching protocols. But then yes, one medical college and one institute may different from another institute, and that's why these questions sometimes, some of us may give you one answer, another doctor may give you another answer. So yes, the best way to know what is the the exact answer to the questions which we are discussing is to read about them properly in the theory books and the right kind of theory books. And for obstetrics, that is Williams Obstetrics, and for gynae it is Novak's, at least these two. Otherwise you could read Shaw's book of gynecology and also Holland Bru's book of obstetrics. All right, I mean there are many other good books, but at least these four are the good reference books. All right, and we'll now get into the discussion about the questions which came, and I hope you'll all help me. This is the time when I want you to tell me what were the right choices, and probably we can build upon the answers which are coming, to our minds. We can build upon them depending on the choices you give us during the live chat. All right, so here we go. Okay. So question number 1, which of the following is a virilizing tumor of the ovary? Now, virilizing tumor means the virilization changes which can happen. These are permanent changes. All of us know virilization means things like clypetromegaly and breast atrophy and hirsutism. I'm so sorry, hoarseness of voice. So how these virilizing these things, how they different from hirsutism? Hirsutism, that male pattern baldness, acne, all that is reversible, but virilization is not reversible. So that's why we say what are the virilizing tumors. If somebody because of the androgen excess gets virilized, a lady starts getting these signs, clypetromegaly, it is not if you correct the hyperandrogenism, this is not going to correct by itself. You'll have to do a surgery for the clitoris, or for the breast which has undergone an atrophy, you'll have to give an augmentation surgery for the breast. So that's why these are virilizing changes or permanent changes. So which of the tumors are virilizing? So out of the arenoblastomas and the theca cell tumors, obviously both are having androgen excess. Of course, I'm not too sure what were the choices, but I think they would have given us a tolylaric tumor also. Was this in the choices? So tell me, what was there? What was there in the question in the exam? Anybody can help me? Yes. Brenner was also one of the options. Brenner, actually, what happens? It's a tumor which is present in women. It's a tumor of postmenopausal women and epithelial tumors of the postmenopausal women, and Brenner is actually known to increase the estrogens. So Brenner won't be the answer. So I don't know whether it was all of the following are virilizing tumors except like that. So Brenner becomes a choice obviously, because if the tumors like Sertoli tumors, arenoblastomas and the theca cell tumors are there, these are all going to increase the androgen. So Brenner does not. So maybe that's the answer. So yes, I'll just mention that Brenner was a choice. Brenner was a choice, so maybe we can build upon this MCQ later. Sertoli was an option, perhaps Brenner was an option. All right, so if these are the options, then obviously that if we say A, B, C and D is Brenner's, then all of the following, which of the following is a virilizing tumors? Well, we can change the question to all of the following are virilizing tumors except Brenner's. Brenner's increases HCG and it is classically associated with postmenopausal bleeding in women who have this. So women around 60 odd years get this Brenner tumor and they will have this postmenopausal bleeding because of the high estrogen. And also remember that Brenner causes the pseudo-Meeks syndrome, the most common cause of pseudo-Meeks syndrome. You obviously know the Meeks syndrome. Meeks syndrome is fibromyositis and pleural effusion. So pseudo-Meeks is any other ovarian tumor besides the fibroma having fibroma, any other ovarian tumor besides the fibroma having ascites and pleural effusion, like a dermoid or a Brenner or a serous cystadenoma. Any other ovarian tumor having ascites and pleural effusion is known as a pseudo-Meeks. So this is one of those tumors. Right, Brenner was 100% an option. So all right, we'll go in. All of the following can cause virilization except Brenner is the right answer. Now let's see the next question. Okay, now this was a question which I am sure the psychiatrists also will be taking care of, but then let's see what the choices came and what you people are recalling for us. A pregnant lady presents to the OPD in the 3rd trimester. She is pregnant and in the 3rd trimester. She is a known case of bipolar disorder with history of 3-4 exacerbations episodes. Okay, during pregnancy. She is maintained well on lithium from last year. I assume that the question means that she is pregnant and is on lithium. Yes, we would say lithium is a contraindicated drug in pregnancy, but the chance of anomalies is around 3%. So people say that if the patient is a very bad bipolar condition patient, then we do go on giving lithium in pregnancy also. So the question is not whether I should give lithium or not give lithium. I assume the question, the way it has come in the language, that the patient is on lithium, she is pregnant, now she's at term. So that's what I'm saying here. She's in the 3rd trimester, nearing term. Okay. So when she's in the 3rd trimester, what do you do with the lithium? That's what is the question, I assume. What is the next appropriate management? So what have you written? Question was, lady with bipolar comes with amenorrhea 8 weeks and UPD is positive, was on lithium, which will be done with regarding drug and options with these that you mentioned. So both sodium valproate and lithium are teratogenic drugs. So if you are giving lithium, you can continue with lithium, and if the question is that it was at term, then we can reduce the dose of lithium. So yes, if the patient is having a lithium tablet going on, the question which is there in my presentation, this answer I am giving you, if the patient is on lithium and she's in the 3rd trimester, so what you can do is best that you can dose can be reduced and discontinued 2 to 3 days prior to the delivery, because there can be a neonatal lithium toxicity. So to reduce that, probably that was the question, but somebody is giving me this another question which probably came. We'll discuss that also. So if the question is that the patient is having a lithium tablet going on in pregnancy, and what can be done when the patient is around term. So when the patient is around term, neonatal lithium toxicity can happen, which is cardiac arrhythmias, hypoglycemia, nephrogenic diabetes insipidus, and the floppy infant syndrome that can happen with lithium ingestion. So we can around term we can reduce the dose and discontinue this drug 2 to 3 days prior to the induction of labor. We can plan the induction of labor, and around 3-4 days before that we can stop the lithium. So that's the question which came to me. For that, that's the best answer. So we can decrease the dose of lithium. So the question which came to me, I'm giving this answer. Now the other question which somebody is saying that question was a lady with bipolar and she's come at 8 weeks gestation. So if it's 8 weeks gestation, then it's best that we can change to an alternative drug, change to alternative mood stabilizers. Of course, that best answer would be given by the psychiatrist friends. So what we can do is that we can change the drugs to better mood stabilizers, and lot of people are managed well with lithium. But remember one thing, people with bipolar disorder in pregnancy, they tend to have these depressive and maniac episodes off and on. They have a lot of problems of preterm birth and a lot of postpartum relapses. So you have to handle these patients with a lot of care. And we always say that it's lithium is teratogenic. You know, it causes the Epstein anomaly in roughly 3% of patients, 3% of the infants. So we have to take a decision of reducing the dose or actually changing it to some other mood stabilizers, which are, you know, it can be combination of 3-4 drugs which can help the patient continue the pregnancy from the early time on, as the question you gave me. Okay. So I'm not saying give sodium valproate. I'm not saying that at all. I didn't say don't give sodium. I didn't say at all that you should give sodium valproate. Yes, sodium valproate is also a category D drug. Yes, category D drug is a known teratogenic. So sodium valproate could be a better option in combination with some other mood stabilizers. I'm actually saying that because see, sodium valproate is a category D drug. Lithium is a category X drug. It's just totally contraindicated. But people do give this, seeing that the patient with bipolar disorder in pregnancy can have worse outcomes. So in reduced dose, it is continued. That's what is a question which came to me in the recall. So yes, it's better that we change the drug at 8 weeks, and if that was a question, if it is at 8 weeks, it's better you change it to a combination of mood stabilizers. One of them could be sodium valproate. It is a category D drug. What is category D drug? Category D drug means a drug which is a known human teratogen, but the benefits of the drugs outweigh the risks, so we go on giving them. Even carbamazepine comes in that category. So but now we have for epilepsy management pregnancy, we have better drugs like lamotrigine and levetiracetam. So those are the category C drugs. So that's why for epilepsy, we have much better drugs. For bipolar disorders, yes, we can think of changing the drug if it is asked in early pregnancy, like the question which was recalled. If it is in early pregnancy, we can change to sodium valproate. Okay. Right. A girl on DMPA. Now, this I don't know at all what was asked. The language of the recall is not good, and the choices I'm not understanding at all. So, what was this question about the depomedroxyprogesterone estate? A girl on DMPA, they have not given me the age and whether she's taking DMPA for contraception or she's taking for endometriosis, I don't know. Periods of the expected date came on the 15th day of the existing cycle. What should be the next step of management? So I'm not too happy with the recall here. So anybody, what were the choices? You can shoot your choices and then we'll see what we can do about this question. 20-year-old girl, all right. She's taking DMPA. Is that for endometriosis or is it for pregnancy prevention? Anyway, what was that? Whatever reason, fine. There was some problem regarding periods. Anyone has a recall? A female was on DMPA, came after missing 14 days. What should be done? Okay, okay. Just type yes or no. From what I recall, you're writing that a patient is on regular DMPA. She's on a regular DMPA, which is given once in 3 months. And when she was supposed to take the next dose of DMPA, she has missed it for 14 days. Was that the question? Okay. So a woman has missed her DMPA. So do you do a UPT before the next DMPA, give the DMPA, give DMPA with 7 days of barrier? No, that's not the right answer. C is definitely not the right answer. Wait for the next period also not the right answer, because if you give DMPA, it causes atrophy of the endometrium, and regular DMP causes atrophy of the endometrium, and that atrophy of the endometrium takes a lot of time, almost 1.5 to 2 months for the periods to come. So we cannot say that wait for the periods. So yes, the best answer is obviously rule out a pregnancy and then give the DMP even if she is late by 2 weeks. So that is the best answer we have in this. So I assume that the patient has missed taking the depot-medroxyprogesterone estate by 14 days. That's what I assume was the question. So that obviously the best answer is this. Okay, all of you answered. Have you written give DMPA? Yes, in 14 days, the woman is unlikely to have a pregnancy also. So if you do a UPT, that will be, pregnancy is known to happen sometimes even when the DMP is given, because the patient does not use, metabolize the drug properly. And progesterones are known to be tricky drugs. If somebody is supposed to take progesterone, they're supposed to take properly on the right time, including the injectable progesterones. So I would say the better answer, the stronger answer here is UPT before the DMPA. But yes, giving the DMP is definitely a correct answer. I would say give the UPT, do the UPT, be very sure, and then go ahead and give the DMPA. All right. Okay. Now, patient presents to the OPD with complaints of PCOS and hirsutism. Which of the following is not a correct management option? What we'll do is that you keep sending in your choices. Obviously, we'll be using this chat for the best choices which have come with best options. We'll obviously be doing a proper recording of all the best answers which we can get after the choices are given. Okay. A patient present to the OPD with complaints of PCOS and hirsutism. Which of the following is not a correct management option? Yes, PCOS and hirsutism. Come. What did you write? OCP plus metformin can be given, and OCP plus androgen, OCP plus weight loss. Obviously, right away, this is the wrong option. We don't give androgens. I mean, OCPs and anti-androgen is the best possible management of a young girl with PCOS and hirsutism. So I'm not too sure. So what were the other choices? Yes, OCP alone, no, not a correct management. The answer is which is wrong. Which is wrong? Yes, tell me. Anti-androgen था, OCP plus anti-androgen. So if it is OCP plus anti-androgen, then that is obviously a good thing to give. So what are the other choices? Yes, guys. So what is not a correct management option? OCP plus weight loss is good for PCOS. OCP plus anti-androgen, if that was the choice, that is also a good option. OCP is anti-androgen. The testosterone levels were also given. OCP plus anti-androgen wasn't. Okay, diffuse videos I got it. Oh, androgen was not there. It was OCP plus anti-androgen. Okay, so that choice has to be removed then. So this is a wrong choice. So I assume it was OCP plus anti-androgens. Okay, we'll take this off. OCP plus metformin, OCP plus anti-androgen, OCP weight loss. Fourth choice, anybody? Galloway score 6 was given. So D, Ferryman Galloway score 6 was given. So that's mild, because anything more than 8 is bad. So 6 is like, okay, she's pertaining to getting towards hirsutism. So OCP plus anti-androgen, lifestyle modification, weight loss, BMI 29 was given. So there's just so much of LH and FSH values were given. So if a person has mild hirsutism, let's say, let me help you with that. Okay, fine. The options will keep coming and we'll use this. Now, if a person has mild hirsutism along with PCOS, what are you going to do? Okay, we are going to give her a combined pill which is going to take care of the hirsutism. So what is that combined pill? So the best management of these girls is we give a estrogen like ethinyl estradiol. So we give ethinyl estradiol, which will cause the proliferation of the endometrium, and we give something like drospirenone. And drospirenone is a drug which is going to cause the patient to have secretion in the endometrium and the anti-androgen action. So we give just estrogen and drospirenone. So combined pill is not exactly estrogen, progesterone and anti-androgen. No, it's not like that. It's estrogen plus progesterone, a progestation drug which has got anti-androgen action like a drospirenone. It can also be estrogen plus cyproterone acetate. Both of these can be used for the management. So yes, when we are saying that estrogen and cyproterone acetate is given, that also will act the same way. Estrogen will cause the proliferation, cyproterone acetate will cause the secretion and the anti-androgen action. So this is the best management we give for patients who have got PCOS, which is irregular cycles, and has got hirsutism. This question has been asked in many ways. They've asked you, a woman has irregular cycles with acne, or a woman has irregular cycle with hirsutism and a Ferriman-Galloway score very high, like that they'll give you. So if that is the question, this is the best answer. So what should not be given? So probably if there was just OCP alone, that will not work. Okay. If you really ask me, if you give combined pills, they will help in some way. If you don't give any treatment for hirsutism, it's bad. So if you give combined pills and 8-9 months, if you give combined pills and the woman has a resting ovary and the androgen levels will actually reduce, so that is not a bad option if you give combined pills alone. It is something better than nothing. But yes, out of these options, if OCP alone is there and then these three combinations are there, then go ahead and write OCP is not the best option here. So yes, probably that is the choice which was wrong. And correct me if I'm wrong, guys. What else did you want to tell me? Yeah, menstrual abnormalities will be present for a patient with PCOS diffuse videos. So I think we'll stay with what has come as the choices, and we'll say if OCPs was there. You mean to say Ferriman-Galloway score was in the question body, not here, and the D choice was COCP. All right, if the D choice was COCP, we'll go and mark that COCP alone is not the best option here. All right, so let's move on. And this drug, you know, which I told you, ethinyl estradiol plus drospirenone is a very good drug. A lot of girls use it, and internationally it is available as Yasmin. In India, we have a substitute called Yamini. So these are the trade names, of course, and they are good drugs which help in the patient's management. Okay, so which infection contracted in pregnancy won't be teratogenic? Come on, this is an easy one. This all of you, I'm sure you would know. Teratogenicity, that means abnormalities in the fetus, anomalies in the fetus causing. Yes. Come, I'll wait for your answer. I mean, I hope these were the choices. This is the only question where I think I've got all the 4 choices recorded properly. Jaydeep, I've seen your answer. All right, that's fairly simple. I mean, 2 of you got it immediately. Okay, chickenpox does, and yes, in chickenpox, especially the first trimester, if a person has chickenpox in the first trimester, we advise an abortion. Yes, I personally don't like to do abortions of live babies, and when there was this patient, one of my own nurses had this long back, and I won't be telling which place, where, but of course we had to go ahead and do an abortion for her because she was having chickenpox positive. I remember my head of the department telling me about this. So yes, it was very, it was difficult. Why? Because the patient had conceived after infertility treatment. And then during her pregnancy, around the 11th, 12th week, she got this chicken pox. So that's first trimester is the worst time to have this chicken pox. Up till actually 15 weeks, it's still worse. Okay. So that we'll go ahead and mark herpes simplex virus. Okay. 65-year-old woman with epithelial ovarian cancer with peritoneal metastasis and ascites. What is the management? So peritoneal metastasis, they have not given the size, but I assume that if it is peritoneal metastasis, it becomes obviously abdominal involvement. If there is an abdominal involvement, it is a stage 3. Of course, it depends on whether it is microscopic peritoneal metastasis or it is macroscopic, but it is less than 2 centimeters, that becomes a 3B. If it is more than 2 centimeters, it becomes a 3C. You know the staging well. So what should you do? Was that the question, first of all? I mean, like, plus or minus some language, some grammar would be there, I'm sure, more than this. But was that the question, first of all? Oh, you're all giving the answers. That's fine. But was that the question? Yes. Peritoneal metastasis and what's the management? Was that the question? Yes, that was the question. Hasipur is helping me with that. So yes, how did somebody know? First of all, you tell me, how will you know that the patient has peritoneal metastasis? So peritoneal metastasis, especially the microscopic one, is known only if you do a staging laparotomy. That is, you're doing a supracholic omentectomy and the omentum goes to the path lab. Path guy sends me a report saying that there is some microscopic metastasis in the peritoneum or in the peritoneal organs, or there is a peritoneal biopsy of a suspicious lesion which I have taken, and that peritoneal biopsy comes to be positive. So that is peritoneal metastasis. So how do I know it is stage 3? Only after I do the surgery. So there's a woman who's got an ovarian tumor. Let's say she's a 60-year-old lady and she's got an ovarian tumor which looks like malignant on the ultrasound. So what do? I plan her for a staging laparotomy and optimal debulking. That's the surgery plan. Never say that ovarian cancer, the plan is TH and a BSO. No, this is never the management. It may require to do a bilateral oophorectomy and a hysterectomy ultimately, but if it is a young woman, then I just take out the involved ovary and leave the normal ovary and leave the uterus, obviously, because she's only 19 with an ovarian cancer. But if she's 60 years with an ovarian cancer, I take out both the ovaries and take out the uterus and whatever else is involved. Maximal debulking, like it is called. So please, TH and BSO don't say is the management of ovarian tumor. Say always staging laparotomy and debulking. Now, how do you know that this is this stage? What has been mentioned? It is only after you're doing a staging laparotomy. So when you've done the staging laparotomy, you found that there is an ovarian tumor, you remove that and also remove the, this age is given, so 65. So obviously remove the other ovary also and you remove the uterus. Now the peritoneal biopsy which you've taken has come as positive, which is stage 3. So if there is a surgery done and there's a stage 3, go ahead for a chemotherapy. So yes, chemotherapy is given after the debulking. So yes, most of you gave me the right answer. What was the stage? What was the fourth choice? Yes, anybody? All right. Peritoneal cake appearance was given. Peritoneal cake. You know what's a peritoneal cake, guys? Peritoneal cake is that the omentum is involved. It gets caked up. So you can make it out on ultrasound and MRI easily. So yes, but at the outlook, it looks like a surgery has been done and then only they found out. Peritoneal metastasis and a peritoneal cake, if it is there, then the answer changes, my friends. So in what you gave me just now, what I have so far, then a 65-year-old woman with an epithelial ovarian cancer with peritoneal metastasis, if that is the original question, then I will say answer is C. But if a peritoneal cake is given, then the answer will be B. It is better I give a neoadjuvant chemotherapy, that is chemotherapy before the surgery, because now the disease is well spread. Because if it is showing a peritoneal cake, then that means it's a well spread ovarian tumor, well metastasized. So before doing a surgery, we can give chemotherapy to control the disease and then go and do a debulking, a secondary debulking with a primary neoadjuvant chemotherapy. So that would be a better answer if you know that there's a peritoneal cake. So yes, if you're telling me there's a cake, answer is B. If there is only this story which is given to me, then the answer is C. All right, so that is an interesting twist to the question, peritoneal cake. All right, guys, so either way, you know the answer now. Let's move on. Antigen present in the HPV vaccine is HPV vaccine. They're asking so many times this HPV vaccine in NEET also and INI-CET also. Yes, what do you want to tell me about this? That's an easy one, right? The antigen is against which part of the human papillomavirus? Yes. Oh, nobody's answering. Hello? All 9,900 of you? Yes, it's against the L1 capsid. Yes, that the capsule or the major capsid, the L1 protein that is of all these serotypes, against this the Gardasil 9 is made. So HPV, you know that it is because HPV is more than 50 serotypes. More than 50 serotypes cause a patient to have CS cervix. But the vaccine which we have, the Gardasil 9, this Gardasil 9 is, I've written G9. Gardasil 9 is good against only these 9 serotypes. So please remember that this is against the major capsid L1 protein. But please remember, even after vaccination, I'm writing vax, give, I mean to say, even after the vaccination is given, continue CA cervix screening. Please don't forget that part, because this is not a sure shot prevention against CA cervix. It is only against the 9 serotypes against which Gardasil 9 has been made. So if a patient has been given the vaccination, all the 3 doses have been given, she is protected only against these 9 serotypes. So give the vaccine, continue the screening. Okay, it's not a sure shot prevention. Sure shot prevention against CA cervix is to have a good dedicated monogamous relation. It's known to, this is the best possible method. Yes, monogamous relations also can have CA cervix. It's not that it only happens to all that early sex and sex with multiple partners with sexually transmitted disease. All that is the major cause. But CA cervix is known to happen in monogamous relations also. But that is still better than giving this vaccine. So yes, okay, that was some personal advice, but what I feel is that just giving the vaccine and telling the patient that you're prevented for anything else which is happening, for everything which is going to happen about CA cervix, that is wrong. Okay. Okay. Uh, there's another question which has come. Findings were on CECT. Okay, that's an interesting twist. If a CECT is done, CECT was done. Contrast enhanced computerized tomography, if that was done, then of course we'll have to, if there is a, when the disease looks like well spread and there is a peritoneal cake, then I would go ahead and give the answer as B. Yes, laparotomy and debulking under a neoadjuvant chemotherapy will give us better results than just doing a primary debulking, if you know if it is so well spread. Mostly what happens, we go ahead and do a staging laparotomy when we know it is contained to one part of the body, that is the ovary, and other things look as if they are not involved yet. It is not an obvious. There might be some suggestion that there are some lymph nodes involved. But if there is no major bulky disease in the abdomen, we go ahead and do the surgery first. But if it is suggestive that there is a big tumor and there is peritoneal caking already, before you go in, then it's better we give a chemotherapy first. But yes, options can be, I'll wait for the options if you have some others. Okay, chalo. Let's move on and see this question. Okay, the question on blood volume increase. Yes, blood volume increase. Yes, this is discussed in the physiology of pregnancy chapter, which we've given you, which you've been given on the PrepLadder forum. And I'm sure you all, those who've read the PrepLadder app, would have read about this. But yes, now let's see. What have you given as the answer? Retention by the kidney, aldosterone and estrogen, aldosterone and ADH, or BNC. I'm sure BNC was not the choice, and this much I'm sure. They don't give such choices. So yes, A, B and C. Anybody, what are you going to tell me is the answer? Omental king Gopinath is that if the omentum is involved with cancer, it gets caked up. That's what I said. I told earlier in the video. There was another option that was aldosterone, estrogen, and kidney retention. Option D is wrong. Yeah, obviously option D won't be there. I'm very sure of that. Okay, this just came to me. The team has been working to get all the. So this just came to me, and I thought we'll discuss with you. We'll get the better choices. Yes. Nitin Nangia is giving me answer as A. Okay, there was an option kidney retention with aldosterone and estrogen. Kidney retention plus aldosterone plus estrogen. Was that an option? Kidney retention, RETN have written. Kidney retention, aldosterone and estrogen, was that an option? Yes, guys? That comes as a close best answer because see, in these choices which have been given to me, retention by kidney, that is the best answer. But yes, estrogen also does cause water retention, and so does obviously aldosterone. So if that was the option, then that becomes the best. Was that an option? So diffuse video says that this was an option, then go ahead and mark that. So the causes of retention, yes, this is the slide. I'm giving this slide straight from my PrepLadder video. So blood volume increases by 30 to 45% at 32nd to 34 weeks of pregnancy, and this is because of the increased sodium retention and decrease in the thirst threshold. Women drink more water because of the decrease in the thirst threshold and decrease in the plasma oncotic pressure. So that is the reason why there is blood volume increase in pregnancy. So aldosterone and estrogen, yes, estrogen is known to be a hormone which causes water retention, and estrogen is increasing in pregnancy. Estrogen is required for the hypertrophy of the uterus. The increase in size of the uterus also because of the estrogen. So yes, there are many things which are attributed to the estrogen, including this. So yes, we'll go ahead and give that answer. Okay, this was a slide, and what was I trying to tell you about hematology in this slide was that red cells increase in pregnancy and fluids also increase in pregnancy, but the fluid increase is more in proportion to RBC increase. So there is an RBC increase, there is a fluid increase, but the fluid increase is more in pregnancy than the RBC increase. So there is net hemodilution. Please don't forget that. Net hemodilution in pregnancy, which is good because if there is hemodilution in pregnancy, thin blood is good for the perfusion through the small early placenta, and thin blood means that whenever the woman delivers, she is losing more fluid than she is losing RBCs. So thin blood is a good thing in pregnancy. One for perfusion, and one, the blood loss in labor is more fluid loss than RBC loss. So yes, what else are you guys telling me? Aldosterone was not there. Kidney retention, ADH was there, which is the best answer. I mean, I was just hoping that ADH was there in place of. So yes, antidiuretic hormone. Alright guys, so we'll wait for the best choices which will be recalled. Alright, let's go. There was a clinical question, my team has also sent me a question like that. There's a clinical question, sir, with uterine inversion and placenta attached. So what are you going to do for that? If there's a uterine inversion, okay, so if you see the uterine inversion, the uterus is having a placenta attached like this. There was a very mean question asked around 2 years back in MCI, that a delivery was done by an intern and the patient goes into shock immediately and dies after the delivery. What was the cause? I mean, it was assumed that the interns will not do control cord traction. They pull the cord without any counter traction and the uterus inverts and causes shock to the patient. And they said intern. I mean, this was an MCI question, I think in June 21. Correct me if I'm wrong. I mean, but this question came with the choice given as delivery by an intern, assuming that the interns probably don't do much of training. I'm very surprised that this choice was given in an exam. I'm hoping that it was a bad recall, and maybe an untrained person did the delivery was the choice. But yes, even if intern was given, I was like, yes, some untrained intern could pull the cord, but I'm sure all interns are reading some or other app and is working in some other institute and then coming and doing internship and is passing exam from some good medical college, and nobody will go and yank the umbilical cord out and cause an inversion. I mean, this is unheard of. Inversion can happen with untrained people, agreed, but it has happened many a times with trained people also. With gynecologists, with obstetricians who are good in the subject, they can also end up with inversion. So I was very unhappy with that mean question. Anyway, so let's get to this one. So there's a placenta attached generally to the fundus, fundal attachment, a fundal placentation, and multiparity. These are the risks of inversion. So when there is a woman with a placenta attached to the fundus and you're doing a good control contraction also, there can be inversion. So you must reposition it back under anesthesia. It is a very painful procedure. So under anesthesia, push the uterus back inside with your fist mostly. The last part which comes, the uterus is like this, it inverts like this. So you push it here, you push it back inside. So for pushing it, you must do relaxation first. Give relaxation with terbutaline, push the uterus back inside, and then give oxytocin to contract the uterus. Obviously, when the uterus has an inversion like this, when the uterus is out and the placenta is still attached, and I have to push the uterus back inside, obviously I'll take out the placenta first. Why was this even a choice? This placenta has to be removed. I mean, you push the uterus back with the placenta, then again you have to pull out the placenta, isn't it? And you'll cause another inversion. So I don't know, why was this even a choice? So let me see what you guys. Manually remove was also given. The option was uteronic oxytocin. See, oxytocin is given. See, that's what has to be given. Nurse was conducting the delivery. Jogi Kamal. Okay, fine. But I will not like that also. Nurses also get training, In my hospital where I'm working, I wish I could give you the name. You can come and see nurses undergo training for delivery because nurses work in peripheries where not many doctors are there. So they should know the basic art. So I don't know. I'm not very happy with the name nurse or the intern. Never mind. Let's get to work. So yes, do you have to remove shift to the OT was an option. Patient was in shock, perhaps, not sure. So yes, if a patient has inversion, she'll be in shock. Of course, immediately shift the patient to the OT. And remember, all labor rooms in all good hospitals, at least I can say that, in all major medical colleges, labor rooms are next to the OTs. So there is a passage from the labor room into the OT. There is always an emergency OT attached to the labor room because these things do happen in obstetrics. So you should not have a labor room which is too far away from the OT. So when there is a delivery and there is a requirement of removal of the placenta like this, take it to the OT, give anesthesia, remove the placenta obviously, then you have to give some relaxation for this uterus to unfold into the body again. So this uterus which has come out like this, it has to go back. So you must relax the uterus. The moment it goes inside, you must contract it with oxytocin. Yeah, shifting to OT is better. Obviously, you'll do it in the OT. Obviously, you'll do. But was that shift to the OT and insert the uterus back? Obviously, it is done inside. Obviously, put the uterus without removing placenta, remove placenta, repose the uterus, shift to OT and insert the uterus back. Obviously, separate the placenta first. All these choices are not properly recalled. In this setting, the best option is this one. Shift to the OT and insert the uterus back. After removing the placenta, obviously, after removing placenta, that goes without saying. So I don't know whether that was a choice, but the way these choices are, I wish they could at least give the question paper, if not the answers. I wish they could just give the question papers in the newspapers next day after these exams so that at least we know the questions are coming. Answers can be debatable, Every hospital has got a set guideline which they follow. Some people follow the American guidelines, some people follow the Royal College guidelines, some people follow the WHO guidelines, and most of us have Indian guidelines also to look at. So which guideline is the one which is the best? So that's why nobody wants to give you the answer. At least gives us the questions. At least give us the questions so that we can tell you what is the best option by practice protocols. Anyway, a woman in labor, cervix is, they've given a dot, that means there's a clinical question. A woman is in labor, cervix is 70% effaced, 3 centimeters dilated, and bag of worms felt. What is the next step? They're trying to tell you that you're feeling the umbilical cord. So when you feel the umbilical cord, rupture membranes and confirm a cord prolapse. That's nonsense. Emergency LSCS, start oxytocin. Were these the three choices? Was there some better choice? In this scenario, obviously take the patient to the OT and do an emergency LSCS is the best answer, obviously, because she's only 3 centimeters and the cord is already coming out. Go and do a cesarean section. Straightforward, that's the answer. But was there some better choice to this question? So, if the cord is felt like this, then this is a very easy question. But mostly what I've seen, INI-CET people have asked you a question that the cord has prolapsed, it has come out, then what do you do? Then do not push the cord back inside. Please, that is a wrong answer. Don't hold the cord and push it back inside. You must not allow the head to press on the cord or the breech to press on the cord. So whatever is the presenting part, that should be pushed inside if possible. If you cannot do it with your hands and it is difficult to do it because the cord is in front, then you can fill the bladder and keep the patient in a knee chest position or in a Trendelenburg position. Knee chest position, that means the patient is in all her fours in the knee chest position, and then in the knee chest position, fill the bladder, of course, and then put the patient in knee chest position or put her in a Trendelenburg position. With that, the presenting part in a knee chest position won't press on the cord. So that presenting part will then now be hanging towards the abdomen rather than pressing on the cord. So knee chest position is good, or the Trendelenburg position is good, so that the presenting part is pushed up from the cord. Take the patient to the OT and do a emergency cesarean section. That is the best answer. So yes, if the release question paper will laugh out, there was question about India company today, sir. All right. Okay, fine. So this is what is the cord prolapse, and what do we do? I've given you a slide from one of our earlier presentations, the snapshot which we had long back. So what is the optimal initial management? These are the Royal College guidelines, and I've given this to you just to show you that this is some things are very clear, that to prevent vasospasm there should be minimal handling of the loops of the cord. Okay, so there is insufficient data to evaluate manual replacement of the prolapsed cord above the presenting part. So don't try to push that. Don't push the cord above the presenting part, and don't hold the cord. Don't do anything handling of the cord. It is recommending that the presenting part be elevated either manually or by filling the urinary bladder, and shift the patient to the OT, adopting the knee chest position or the left lateral position, and then take her to the OT and do a cesarean section. All right, guys. Chalo. -3 station, not +3. Okay, -3 station was there in the question. Okay, fine, we'll keep it that way. Wait and watch an option was there. Wait and watch for spontaneous labor. Tocolysis was an option. Anyway, so let's move on. A clinical case was there where a pregnant woman of 30 weeks with painful bleeding PV with reduced fetal movements, uterus had increased tone, looks like abruption already, uterus has a size of 34 weeks. At 30 weeks, if there's an abruption, so that abruption caused the uterine size to obviously increase more than the size of gestation. It is apparently a larger uterus than the exact pregnancy duration. So yes, the uterus is 34 weeks, fetal heart rate is absent, and blood pressure is 160/90. Always remember, abruption will be given to you in the settings of hypertension. The most common association of abruption is with hypertension in pregnancy. So PV revealed a 6 centimeters dilated cervix and 70% effacement. Vertex is at -3 with intact membranes. What is the next best step? I mean, this question is, begging to have a very simple, easy answer immediately. Tell me. Emergency LSCS, start antihypertensives in ARM, start antihypertensives and do an emergency LSCS. There are 3 options given. What are you going to say as the options, answers here? Come on, guys. Abdul Hanan has given the answer immediately. Anybody else with a different answer? Look, abruption per se. That answer is correct, Hanan. Abruption per se is not an indication for a cesarean section. Just remember that. Abruption per se is not an indication. Abruption may end up in a cesarean very often because the uterus is having a bruise. Remember, bruised uterus. There is blood in the uterine muscle, covulate uterus as you call it. That bruising is the cause of pain. We all know that there is painless bleeding in a case of placenta previa. There is painful bleeding in the case of abruption. Why is there pain? Pain is because the abdominal muscle, the uterine muscle has some blood which has gone in, and that uterine bruising is the reason. So that bruising is causing painful uterus, painful bleeding. So when there is painful bleeding and there is hypertension, think of abruption as a cause of bleeding. And the blood clot which is below the abdominal wall and below the anterior uterine wall, that big blood clot, that prevents us from hearing the fetal heart sounds many times. So the heart sounds could not be heard sometimes, although the baby is alive, or the baby is dead. So if the baby is alive, do a normal delivery. If the baby is dead, definitely do a normal delivery. You don't have to do a cesarean for a dead baby. So if the baby is alive and is having distress, then you go and do a cesarean section. So abruption per se is not indication for cesarean section. Abruption with the fetal distress, yes. Abruption with a live baby, perfectly normal heart rate on the ultrasound, do a normal delivery. Abruption with a dead baby, again do a normal delivery. Okay, dead baby is never indication for a cesarean section. All right, I mean, don't go for, there are exceptions to all rules which we keep saying, but dead babies, we don't do cesarean sections unless there is really something drastic happening. So that was fairly easy question. Now, case of a question, I mean, a clinical question which we don't know the language, that's what has been given to me. A 39-year-old, Grada 6, para 3, A3. So she's a pregnant lady. So this formula is wrong. Obviously, it will be Grada 7, para 3, A3. I mean, if there's a woman with 3 children and 3 abortions and she's pregnant now, it has to be Grada 7 with 3 previous cesareans and a placenta accreta syndrome. PAS means that. What will you not counsel her? Look, what is PPCM? Postpartum cardiomyopathy. I am so sorry. This short forms sometimes, I mean, like, sorry for the ignorance. Is there some exciting acronym which I am missing? Anybody? G6P3A2. Okay, fine. So my friend say that this was also not the option. The option was G6P3A2. All right, that's the question then. PPCM. Yes, I want to know what did they mean by PPCM. Was this a choice? Option 3 was not there. देखा ना यार, इतने भी हम लोग अनाड़ी नहीं यार. I mean, I don't know. I mean, so many of these acronyms baffle us sometimes. It was hysterectomy. There was something about a hysterectomy. All right. Risk of blood transfusion, yes. And bowel injury. So yes, what will you not counsel her? There is a risk of bowel injury, obviously, because any cesarean has a risk of bowel injury. So placenta accreta syndrome, if the placenta accreta is the one which is like the placenta percreta types, if it is going till the surface of the uterus, there can be bowel adhesions and bowel injuries. So I'm not too sure what they were trying to ask. Risk of excessive bleeding, yes. Risk of hysterectomy, yes. And risk of bladder injury, definitely. So which is not going to happen in placenta accreta syndrome? Previous 3 LSCS as it is has a high risk of adhesions and bowel injuries. Just the previous 3 LSCS itself has. With placenta accreta syndrome, definitely it has more. So PAS, am I missing this acronym for something else? Am I misreading the acronym? Was it PAS or was it some other syndrome? Am I correct in discussing placenta accreta syndrome here? Can you please tell me? Hysterectomy is a definitive risk. Placenta accreta syndrome, if it is just placenta accreta also, we have ended up in hysterectomy so many times. Placenta increta and percreta, much more higher chance of ending up in an obstetric hysterectomy. That's definitely. So I'm not very sure what choices came to you. I mean, if you ask me, excessive bleeding, risk of hysterectomy, risk of bladder injury, and bowel injury, in this 4, if this is not the choice and this is, let's say, C and this is D, suppose, then I would say risk of bowel injury probably lesser than the other 3. I mean, like, if these are the choices, But all these four can happen. Definitely they can happen. Placenta accreta syndrome bleeds like crazy. The worst bleeding I've seen, apart from PPH, the next worst bleeding, in fact probably worse I've seen, is with placenta accreta. I mean, you take out the placenta, it doesn't come out, it breaks down. You know, you've done a delivery just now, you've done the control cord traction, and moment the placenta comes out, you're very happy. Now the placenta doesn't come out. So what do you do next? Retain placenta, what do? You put your hand, take the patient to the OT, put your hand and try to take out the placenta with your hand, manual removal. But now you see the placenta is so badly stuck that even your manual removal is not able to take it out, and the placenta breaks into pieces. And the remaining placenta with open sinuses, it floods the uterus, it floods your whole of your floor of the OT, the blood falls on you. That kind of bleeding, if you see, you'll be scared for your for the patient's life and your career next. So that kind of bleeding I've seen so many patients, and we have ended up in hysterectomy more often than than you would like to imagine. More than 50% of these patients end up in hysterectomies, but I'm not quoting a book, I'm telling you what is my experience. We are able to save only a few such uteruses. So this placenta accreta syndrome is the biggest scare we people have. So hysterectomy is definitely a option which can which is seen in placenta accreta syndrome. Yes, what are you guys saying? Can PS be related to synecdoche as she has some procedure of abortion? Yes. Placenta accreta syndrome is because of uterine injuries like DNCs and LSCS and myomectomies. All of these are known to cause placenta accreta. The most common association, no doubt, is placenta previa. Placenta previa is the most common association of placenta accreta. But yes, uterine surgeries and uterine injuries are also. Previous LSCS definitely is it. So yes, the number of patients who are having previous LSCS, very soon I think we may have to change the answer from placenta previa as the commonest association with placenta accreta to that previous LSCS is the commonest association with placenta accreta. So we may have to change the answer because there's so many more cesareans happening these days. All right, so if these were the four choices, A, B, C, and D, the ones which I've written now, then risk of bowel injury is probably the least likely to happen. I mean, she will bleed a lot, she will have risk of bladder injury because the interface is mostly how do you diagnose placenta. How do you diagnose a placenta accreta? We say the retroplacental hollow between the placenta and the bladder is lost. It's a classical thing. So bladder is over the part of the uterus where you generally see a placenta accreta because previous LS is mostly done on the anterior wall of the uterus. So anterior wall of the uterus, we move the bladder and then we make the incision, isn't it? So when you have a bladder stuck to that part and a placenta accreta is below that, so bladder injury is a likely option, likely possibility. All right, so again, the choices are a little unsure what you have, what has been given to me. In this current scenario, I'll probably write A, but that is with a heavy heart because all these four actually can happen. All right, so that is the questions which I got. Was there any question which you want to tell me? Somebody was saying that there was something regarding choledochal cyst. So I think I'm sure the surgeons will be giving you the best answer. Something regarding a choledochal cyst with something to do with OCPs. I mean, OCPs, what I remember about OCPs and the gallbladder is that OCPs is known to cause gallbladder stones and not gallbladder cancer. And OCPs can cause hepatic adenomas and not hepatocellular cancer. So this is what I want to remember about. But what about choledochal cyst? Was there a question? Yes, anybody? Or was it choledochal cyst with PCOS? I mean, there was some correlation between something to do with choledochal cyst and a gynae topic. Nobody is able to recall? Oh, come on, 177 of you. Come on, somebody must have given this exam and you should remember. Option A, sir. That option, okay, fine, that's okay, that's over. Anybody else with a... Okay, you can ask me any doubts if you have, guys. If you have any doubts regarding the questions which came in the exam today regarding obs and gynae, because this is all what I have with me. Okay, Rahul Rathore. So choledochal cyst, I think there was just mentioned by somebody, so I think we'll give it a skip. So yes, good that I had this discussion with you. You've given me a lot of choices which were not given to me initially by the team, so we can build upon these questions and we can make a proper video and come back to you guys with the answers of INI-CET November 23, very soon. All right. So if you don't have any other questions, and fibroma, can fibroma cause ascites? Yes. Passing question, anybody? Fibroma, yes, fibroma of the ovary is associated with ascites and pleural effusion. So, how it causes ascites and pleural effusion is a little difficult to explain, but if it is associated, it is known as the Meeks syndrome. That is classical, okay? Fibroma of the ovary, ascites and pleural effusion. That is classical Meeks syndrome. It's a hot shot MCQ for 2 exams. One is INI-CET, one is the MCI exam. NEET exam, they'll ask you pseudo-Meeks syndrome. They'll not ask you a very simple question like that. So, yes, Meeks syndrome, Krukenberg syndrome, and don't miss out on those. And the other one which they'll ask you is about the management of an ovarian tumor in pregnancy. So, in INI-CET and MCI, they asked you that if there is a asymptomatic ovarian cyst which is large, what do? You must remove, because it is asymptomatic now, it may become symptomatic later. So, there is a uterus with a large ovarian cyst, say something like this. Patient is pregnant. So, if there is a big cyst like this, it is asymptomatic now, may become symptomatic later. So, yes, it can undergo a torsion and a rupture and a hemorrhage. So, better time to remove is the second trimester. So, that is INI-CET and MCI question. NEET exam, they asked you that if there is an ovarian tumor diagnosed in the third trimester only, then what do you do? If it is diagnosed in the third trimester, then you wait for the delivery to happen, and in the first week or the maybe 10 days odd after the delivery, do a removal. Then you can do a laparoscopic cystectomy also. You don't have to do a laparotomy. So, after the delivery, you take out the ovarian cyst within the first 1 or 2 weeks. You don't wait too long. Earlier we used to say wait till the end of puerperium. What happens when the uterus is reducing in size? Then as the uterus reduces in size, the ovary bumps onto the abdominal wall and may undergo a torsion. So, it's best that you remove in the first week after delivery. All right, guys, what is latest MMR? Latest MMR, the one which I know, is 97 maternal mortality rate. So, last year around Jan odd, it was 143, then it came down to 113, and it's now 97. So, yes, but yes, please discuss with the doctor of PSM. I mean, she's also going to be having the, why don't you put this question to her? If it came in the exam, I'm sure they would have given the latest. Latest is 97. All right, Dr. Casanova, you got your answer. Dr. Lulu, hi, and Dr. Anas, realizing causing ovarian tumor. That was the first question we discussed, Swapnil. So, go through the chat and you will get to know the answers which we've discussed already. Right, guys, thank you so much. Wonderful coming on a live forum with you guys, and please send in, as the chat closes, you can send in your queries into the, under this YouTube video. You can ask me questions even otherwise, rather than just than in this live chat. You can come back to me and ask me the questions. Happy to get back to you anytime. Thank you so much, guys. See you very soon.